Good evening, everyone. Welcome to the Citizens for Healthcare Action. I have to learn who I'm speaking for tonight. The Citizens for Healthcare Action Healthcare Forum being presented, and unfortunately minus one of our speakers. Steve Kulik, who was supposed to be here, was in the legislature all day today, and just 10 minutes ago I was speaking to him from the back seat of the House, and he is still in Boston. So he sends his regrets, and I'm afraid to say that I'm going to be surrogate Steve, which is never a good thing. Citizens for Healthcare Action consists of the following people who are here. If you would all stand up and let people acknowledge all the hard work that you did to make this thing come together. Pam Thompson, Peggy Kleiman, George Coling, Mark Shapiro, Marcia Coling, Eve Voorhees, and Cynthia Jurak. Thank you. And they have asked me to mention to any and all of you that they are a very welcoming group who are looking for more members. So if there is any interest in your part after tonight's meeting, I believe they will have a sign-up sheet and a box over there to put things in. So let us get started. In 2006, a Republican governor and a Democratic legislature created a first-in-the-nation health care plan that led to a nearly 100% coverage rate for health care in Massachusetts. Many hailed it as a breakthrough in health care reform, and most suggested that it at least inspired the Affordable Health Care Act, which followed in 2010. Now, as we sit at one of the many historic precipices of healthcare reform, Massachusetts once again has the opportunity to lead the way. Recently, Alabama Congressman Mo Brooks noted that most people with pre-existing health conditions are afflicted because they don't, quote, lead good lives. Congressman Paul Labrador of Idaho noted recently that, quote, no one dies because they don't have health care, unquote. Personally, I believe that we as Americans, we as human beings, are better than those sentiments. And certainly Massachusetts has demonstrated that it has compassion in the creation of healthcare legislation, as evidenced in what we created in 2006. And that is why we're here tonight, because we stand at that precipice again. We have assembled 3/4 of a stellar panel who will look into our future and give us a glimpse of how we, the Commonwealth, will hopefully lead the way once again. Years ago, I met a guy who was a moderator who I thought was exceptional. And I asked him what his secret was. And he said to me, there are just two things you need to do. You have to realize that all the people who are on your panel are way smarter than you are, way more informed than you are. So therefore, you have just two jobs. One is to spell out the ground rules so that everybody knows what they're going to be doing and why, and then get the hell out of the way. It was the best advice I ever got. So we have such a panel tonight, but before I introduce them, I now have to do those very ground rules. And I thought I had 3 when I came here tonight, and in the half an hour that I've been standing around, I think I'm up to 9 now. So there are blue pens put out by the National Committee to Preserve Social Security and Medicare. They are on the side. They are your parting gift tonight. Through this door right here, over on the left-hand wall are the men's and women's rooms, and a water fountain is in between. There is food on this side. There are many, many handouts. I hope you've gotten them all. The important 21st century message I have to present: it is now time to turn off the stupid devices that are in your pockets and make sure there is no beeping, ringing, buzzing, etc. The original plan was each speaker was going to speak for about 15 minutes. We're now going to bump that to about 20. Obviously, if they don't have that much, hopefully you will have lots of wonderful questions later to fill the time with such a great panel up here to answer those questions. I would ask that everyone, when you are ready to come up and ask a question, there's a microphone here, a microphone there. I know everybody says they have a really strong voice and everybody can hear me when I stand at my seat. However, we are recording tonight, and if you do not speak into those microphones, we will not know what the question was that is being answered by one of our panel. So it is very important that you come up. If you think you've got a question, somebody's already up, feel free to come up, stand along the wall, stand behind them so that they can, so that we can know and keep the questions moving quickly. I ask that everyone use tonight to be the night to refrain from the ugly politics that we've all been going through for the last 4 months. Every so often we could use a night off, and I'm going to deem as moderator tonight as night off on nasty politics. There are anonymous surveys that are on everyone's chair. If you get a chance to fill them out, the group putting on this event tonight would love to have your feedback on healthcare issues. And there's a survey box right there on that table. I think I've covered all of the logistical issues. And so I am going to now begin with Eliza Lake, who is a Worthington native and the CEO of the Hilltown Community Health Centers, which is celebrating its 6th decade of healthcare for the Hilltowns, and a wonderful organization that I've been going to for many of those 6 decades. They have been around to provide affordable and accessible healthcare in Western Massachusetts. You will also be the one introducing our navigators who are here tonight, so that any of you who would like to schedule appointments to answer your individual insurance option questions can speak with those navigators after the fact. So without further ado, Eliza Lake.
I realized if I sat up there, I can't see my own slides, and I can't. Yeah, there we go. Great, thank you, and thank you for having me. And it's awfully nice to be able to do something between my office and my home, 3 miles in one direction and 1 in the other. So this is an unusual occurrence. And I want to thank Evan for his leadership in town for these many years, and I'm glad we could pull him back into the public eye so quickly after he stopped being a selectman. So, and before I start, I do want to introduce Beulah Mae Thomas and John Bergeron, who are navigators at Hilltown Community Health Center, and their job, and I'll actually mention navigators a little bit later, is to be the experts. Actually, they are the true experts in the room, I would say, on healthcare, because their job is to help people get access to coverage that helps them remain healthy and well. So appreciate you guys coming, and there may be questions that people ask that actually you would be better able to answer than I, and certainly if you have specific situations, they will be able to help you. And then there are a few other people here who work at the health center. Laura Grimes, Diane Meehan is here, Janet Dimmick. I think that's everybody, but I really appreciate everyone coming. So what I'm going to talk about, and maybe not as quickly as I had originally planned, is to talk a little bit about Massachusetts gains and the current reform efforts and how they could affect what we have in Massachusetts now. What community health centers are in Massachusetts, because I think particularly in this area, the health center has been here for so long and so many people have been going there that they don't actually know what our role is in the larger healthcare system, and particularly at the federal level, what our relationship is with the federal government. And what the current federal and state outlook, I had originally threats, but I decided outlook was a nicer word. So it's sort of a grim outlook, but it's an outlook. And then what you can do. And Evan was saying that we would be providing a glimpse of the future, and I am thrilled I'm going first so I can be the person to say, you know, it's complicated. Healthcare is complicated. and that, quite honestly, I have no crystal ball. I don't think anyone does about what's going to happen. And then the last thing I'd say about that is I feel like 2 years ago doing this would have been not intimidating at all because I do healthcare and you know, I know about these things. But now I feel like everyone knows about healthcare. I mean, the amount of time people, a lot of us, I think, are spending keeping up with what's going on. There may be things that you've done more reading about than I. So, okay. So, first thing I'm going to say is not only did I steal these slides with permission from the Blue Cross Blue Shield Foundation of Massachusetts, which is a phenomenal research organization, but they stole this cartoon, and I think it's maybe not even legal to use, but I still think it was good, just showing the confusion that's out there, desperately seeking someone to explain the difference between Obamacare and the Affordable Health Care Act. And this is what we're seeing out there is people are confused. And for those of you who don't know, they're the same thing. So this slide shows what Massachusetts did in 2006 in terms of healthcare reform, Romney Care as it has come to be called, and then and also in Chapter 58, but then also in 2012 they passed the financing part of that bill, of that effort, and then what the ACA did in 2010. So this is sort of the progression before we got to the current state. And I mean, I don't need to go through all of it. They're very similar, I think, is the takeaway. They both have affordability exemptions, meaning that if you don't have access to an affordable plan, that your employer has to offer you an affordable plan, and if you don't, then you can buy into an exchange. MEC, I'm trying to remember what it stands for, but that's the minimum benefits that you have to be offered. They both expanded Medicaid. Massachusetts expanded it for kids up to 300% of poverty, and then the ACA expanded it up for everybody up to 133% of the federal poverty line. And then Massachusetts subsidized insurance for adults up to 300%, and that has been maintained, but the federal government has tax credits for people up to 400%. And you guys would know better than I how much that is, but my memory is for a family of four, it's like $90,000 or something like that. For what, 400%. So it goes up pretty high. Both of these pieces never happened. Massachusetts had a small business employer responsibility that employers were going to get penalized if they didn't offer health insurance that was affordable. And when the ACA came in, the state never implemented that because they figured this would supersede it. But then this was never done because, well, it was never done. There's been concerns about the impacts on small businesses. And then the insurance market reforms, and what this down here, which you can't see, says is that those actually were in place before, some of them before Chapter 58, is issues around pre-existing conditions, discrimination, and then controlling the age bands. And what an age band is that somebody who is older can't pay any more than 3 times as much as someone who is younger, or two times in the case of Massachusetts. So they're pretty similar. Massachusetts actually, I would say Chapter 58 was stronger. I mean, John could certainly speak to that. When the ACA came in, Massachusetts actually had to provide plans that were not as good as what the plans that they were required to offer to people were not as robust as what Massachusetts had required before. So right now in Massachusetts, coverage, in terms of individual responsibility, we have a mandate for health insurance. There's a requirement that it be affordable and that people pay a penalty if they do not have health insurance, but they don't pay a double penalty if the ACA, you don't pay both a federal and a state penalty if you don't have health insurance. They figure out the difference if there's a difference, and you pay that. We transitioned from Commonwealth Care, which was the original part of the original Romney Care, to the connector, let's see here. So people went from Commonwealth Care to Mass Health, and then there were different ways of supporting people being able to get coverage, but it, as I said, maintained it up to 300%, and then federal tax credits for people between 300 and 400. And this is all important to understand then what is going to get undone. And again, we talked about those. So in Massachusetts today, we have the highest coverage rate in the country at 96%. What I would say as a community health center that my colleagues more than here in the Hill Towns serving an immigrant and refugee population, that 96% doesn't actually capture people who are undocumented. So in the state, community health centers serve about 20% of their patients are uninsured, which everyone always says, well, how could that possibly be? We only have 3% uninsured. I mean, obviously, the numbers, math is complicated, but, and it's partly because that number does not capture people who are not on the rolls. There were a lot of issues when the ACA was implemented, which John knows better than anyone, and any of you who tried to get coverage through the connector, there were real issues, but they've all been resolved. There continue outreach to the remaining uninsured, and so that is where the navigators come in. We are a navigator organization as opposed to a CAC. What does CAC stand for? Certified Application Counselors, which help people sign up for insurance too, but as navigators, we go out and try and find people and do this kind of active outreach. And right now, Massachusetts is in so Chapter 224 passed in 2012, as I said, that's the financing piece of Massachusetts healthcare reform, and it said that there have to be, Mass Health in particular, which is the state Medicaid program, has to really start focusing on cost containment, and in fact, and I'm going to talk about a waiver that we have with the federal government soon, but Mass Health is being radically restructured this year, and by the end of the year, and it won't, theoretically won't affect patients from a patient's perspective, but it's really changing how providers think about care, how providers think about balancing quality and cost in an attempt to, at least, as they say, bend the curve. So if the curve is like this in terms of growth, well, like this in terms of cost growth, trying to get it to kind of be a little, not grow as quickly. And that's a number I don't have in my head, which I think Steve would have, which is the percentage of growth of Medicaid spending over the last however many years. So this was put together around, oh shoot, you can't really see the bottom. Might as well pull it down because we can just put it up again. Hey, look at that. So this is slide was created around the AHCA the American Health Care Act, which is the Republican bill, as it was in March, I went back through this and looked at it, and there are not a lot of changes in the bill that was passed May 4th. But so in terms of eligibility, there's not a lot of changes in the new federal law, except the states may be able to require able-bodied Medicaid recipients to work. They did this in Indiana and I think a couple other states to have a work requirement for people in order to get Medicaid. But it can keep, I guess I should say, some of the expansions, and then it theoretically, I guess, keeps the tax credits for people between 300 and 400%, but there's a caveat to that. So states can do all kinds of things to change who or what you get with your health insurance plan. So the big one, community rating means it's a way of keeping premiums from being wildly different, but the essential health benefits is a really big one, and I'll talk about that in the next slide. Higher premiums after lapse. I believe the original bill said that if you lapsed your health insurance, then you have to pay 30% more when you come back on. Now the new bill says, well, they can look at your medical history and determine what your premium will be based on that. And what that's going to do is people are going to drop off, because people always drop off because their lives change, and they won't go back on. So that you can increase the bands up to 5 to 1, so elders will have much higher premiums. No individual or employer mandate, which will mean that healthy people will not get health insurance, and therefore the acuity of the people who are insured will go way up. Premiums will go up. It'll become more expensive. The risk pool becomes much riskier. States can impose higher premiums for pre-existing conditions, but parent coverage is still applicable to people up to 26. It's like the one thing that seemed to stay the same. In terms of financing, it eliminates all the federal support for these people between 300 and 400%. So if you can afford it, you can buy a plan, but you won't get any tax support. You will, but it's limited to $2,000 to $4,000 based on how old you are. So I just saw a chart. For somebody over 60, your premiums could be $14,000 a year versus $7,000 now or something like that. I mean, it's just a huge difference. And then the reason that it passed the House in May is because there was so much concern about the pre-existing condition piece that they put $8 billion in for funding for high-risk pools, which means basically putting people who have high risk in a separate pool. So they're not theoretically affecting the premiums of everyone else, but history has shown this doesn't work. So that's the potential federal stuff. These are the essential health benefits right now that are required under the ACA. So pretty much everything. Emergency services, hospitalization, maternity, newborn care, mental health and substance use disorder services, prescription drugs, preventive and wellness services and chronic disease management, pediatric services. I mean, I honestly haven't thought about what isn't on this list, but and so states, what the bill says is states can determine what of these they want to offer, what of these they want to require plans to have. Right now, they're all required to be covered. So this is just quickly Medicaid's current financing structure. Right now, it's a guarantee. It's called an entitlement. That if a state spends $1, Massachusetts spends $1 on Medicaid, the federal government has to give us 50 cents of that back. In fact, it's a little more complicated. Mass Health Standard is 50%. The Children's Health Insurance Program is 88%. And then the ACA expansion, those people who weren't covered before but now are, is 86%, et cetera. But what it comes down to is $13.7 billion in 2015, so it's a little old, including state and federal funds, and 50% average match. And that number is about, well, in this most current year, the Medicaid budget is 42% of the state budget. So it's huge. So this just shows you some of the things they were talking about, how to change Medicaid. And I'm going to really focus on Medicaid because it is, first of all, 1 in 4 people in Massachusetts receive Medicaid. It is 42% of our state budget, and it is the most vulnerable folks who use it. So what they decided to do is a per capita cap. So this is right now, federal funding, you spend $1, you get your reimbursement. So therefore, both the state and federal government share risk. The trend is just totally depends on how much the state spends. So therefore, when public health crises or medical advances happen, you spend more and you get more money back from the feds. The state has flexibility in terms of how they do it. That's a Section 1115. That's the waiver I was talking about that I'll talk about a little bit more. And the state matches. What they've put in the bill is a per capita cap, which is not probably as horrendous as a block grant, but it's not great. So they look at how many people there are. Maybe they look at by what types of, elders versus children or whatever, but they assign a number. This is how much money the state will get per head, and they give it to you as an amount. The problem is that then there's no flexibility. So the state bears all of the spending risk. There's a little bit of a trend upward, but it's not going to be at all responsive to public health crises or other issues, so the state will be on the hook for any money that they want to spend on those things. And then, it all sort of follows. So that's what's in the bill right now, and it seems like that's what the Republicans want. Then the bill also includes a lot of state flexibility, which basically means letting each state do whatever they want. And in Massachusetts, and I think Mike's going to talk to this, we have a commitment to this. The administration has been extraordinary in their commitment to what we have, but other states do not have that commitment. And I just heard the other day about Maine is already filing a waiver that would require, I don't know if they're requiring work yet, but there's just, it's trying to scale back what the healthcare system is doing dramatically. So the states can make changes to coverage. They can cap enrollment or create waiting lists. They can say that open enrollment only lasts for a week, or if they wanted to, so everyone has to apply. Paperwork requirements for people. They can obviously modify the benefits or require premiums and co-payments in a way that they don't now. And then they can change scope of benefits and what managed care companies can do. So this is really important. These are, we keep talking about bills in Congress, but there's lots of ways in which the federal government can change healthcare. So there's legislative, these bills that we're talking about. This is a lawsuit that right now I can't remember, I don't feel like in the last 2 days whether I've heard whether the Trump administration is going to go to the Supreme Court to defend the ACA, which Obama was doing or not. But then there's regulatory processes. So essential health benefits, they can change without legislation. These waivers, Massachusetts has a multi-billion-dollar waiver that got approved and goes into effect July 1st, and it will fund a lot of the transformation of our mass health system as well as our health safety net. Okay, I'm sorry. No, I know. Is it really 20 minutes? There's no clock anymore. It's like I have no idea what time it is. Shoot, I've got a lot to cover. So anyway, and then there's executive orders. So there's lots of ways in which things can be changed. Okay, so moving on to health centers. Really quickly, what is a community health center? A federally qualified community health center. It provides primary care services that address physical and mental health as well as social determinants of health. Social determinants of health are things like poverty, housing, food security, education, sort of the whole host of things that can affect people's health. The requirements of federally qualified health centers like Hilltown is that we have to serve all patients regardless of their ability to pay. We cannot turn anyone away. Our board of directors has to have 51% consumers. And I actually don't see any of our board members here, but they all live here in the community. We have to provide coordinated care. That means that our medical, dental, behavioral health, all of our providers work together on people's health, and has to be located in an area that is and serve patients that are medically underserved. So there are 1 in 7 people in Massachusetts currently go to a community health center. We're the largest primary care network in the state. Almost 1 million patients in Massachusetts go to a community health center. We save $1,200 per patient annually in healthcare costs, or more than $1 billion a year for the state. And we use population health management model that, as I said, involves a lot of integration of care. As Evan said, we've been here for actually 67 years. 1950, Florence Bates started the Worthington Health Association. We serve 8,300 patients in the last year, roughly, that come from 120 different communities, 120 different zip codes, people from pretty much every community in Western Mass. We have 4 sites in Worthington and Huntington, and then we're opening an Amherst site in 2017. We're recognized for our patient-centered medical home model. We do all kinds of things out in the community, including we now have mobile dental in local elementary schools, a school-based health center. We have the only domestic violence victim advocates in the hill towns work at the health center, things like that. So we're mission-driven. This just shows you where the health centers are in the state. So we'll have another one here in that hole. But so you can see they're everywhere. Health Center's vision is communities engaged for health, and our mission is creating access to high-quality integrated health care and promoting well-being for individuals, families, and our communities. And this is brand new. We just came up with this, so I had to put it up there. And then these are really quickly. I have some copies of my slides, and then I have a thing you can email me if you want them. But just some of the data. This is another Blue Cross Blue Shield study that shows the people who don't have health insurance in Massachusetts and why. Cost, language barriers, churn because of work, things like that. And then in Amherst, one reason we're opening is limitations due to language and geography, but finding a place where people speak your language and you feel welcome has been hard. This is really quickly just dental, because dental is something people don't think about, but access to dental is a huge, huge, huge issue. So, and we can get paid to do dental care for people on Mass Health. We can do almost anything. Private dentists can only get paid to do fillings in the front and extractions in the rear, besides preventative care. So that's why we get people coming from the other side of the Quabbin to get dental care from us. Okay, so here's the less cheerful part. So cuts to Medicaid and Mass Health funding. If they go to per capita federal spending, that's a huge threat. And the 1115 waiver, as I said, is going into place July 1st. And I don't know if Mike's going to talk about this. My understanding is that the feds are not talking about taking that away, but if there's no money to implement all the reforms in the waiver, then I don't know what's going to happen. Reductions in coverage for low-income residents, and particularly that group. Community health centers, we get about 1/7 or more of our budget from the federal government. We have to do all those things that are required in exchange for getting this money so that we can serve people without insurance. Congress has to reauthorize that funding by September 30th, and if they don't, we lose 70% of that grant. All health centers do. So if you combine that with what might happen with Medicaid, community health centers are seriously, we're facing kind of a, well, they keep calling it a cliff. I feel like everybody calls it a cliff. But massive cuts to social service programs. Pretty clear from the news today that the president's budget that was filed yesterday is dead on arrival. But it does show you some of the thinking that's going on in Washington around fuel assistance, SNAP, food stamps, Meals on Wheels, all of these programs getting either zeroed out or severely cut, and that will affect the health of people in the state. And then a really important piece for us is workforce recruitment and retention. It is very few people are going into primary care now, and their doctors want to be specialists. It is incredibly hard to find fantastic primary care providers. And one of the tools that we have is support from the federal and state governments for loan repayment and other ways we can support people coming and working for us. So, tremendous budget impacts to the state. On the table there is a report that came out yesterday from Blue Cross Blue Shield and the Urban Institute about the actual impact of the AHCA on Massachusetts specifically. $2 billion hit to the state budget in Medicaid, which I wish Steve were here because he could tell us how they're going to solve this problem. But I imagine it could result in changes in Mass Health eligibility and coverage. I will tell you that in the past, the first thing that goes is dental coverage under Mass Health, often. Support for health systems transformation. We're all geared up to change how we do things so that we really are looking at total cost of care and changing how we're providing care to people, particularly with Mass Health. But we need support to change all our systems, and that will go away. I mean, that could go away. And then again, workforce. So $2 billion loss to state budget. As many as 500,000 Massachusetts residents could lose their health insurance by 2020. The report that came out yesterday, as Steve said, well, it's a little better. It's only 455,000 people versus the 500,000. But 90,000 of those are people who, because are between 300 and 400% of the poverty, or are, it's people who are losing the support for their premiums. And then if the Medicaid expansion goes away, that's another 355,000. And then if we don't get our funding for health centers, nationally it's 9 million people losing potentially their coverage, but in Massachusetts it would be 58,000 residents, and that would just be if the health centers stayed open but couldn't provide care for people who didn't have insurance. Whether the health centers can stay open is another question, and so that would be almost 1 million people. So what can you do to help? Become a health center advocate, and of course I'm using this as my bully pulpit to tell people this, but you can sign up to get alerts when you should call the Congress, and so I decided rather than giving everybody killing tons of trees, I put out this over here, which has the sign up that you can sign up, and you get occasional emails and things telling you call your congressman to make sure health centers stay alive. On the back, I put how to contact all of your elected officials, regardless of where you live. And then there it is again. So, thanks. Sorry for being indulgent.
I think if we were ever to do this again, we might invite Liza back to just do this all by herself. I'm going to try to segue as best I can from Steve Kulik to Mike Knapik to Jackie Wolf, and what I'm going to be telling you is what I got in a phone call from Steve about 15 minutes ago sitting on the front porch. So Mike and Jackie hopefully will correct me where I go off the rails, but I wanted to sort of give you an overview of what Steve wanted to say tonight. First and foremost, he pointed out that the healthcare component of the state budget right now represents 41% of the entire state budget, as Eliza was saying. And for the fiscal year 18 revenues, 60% of this current budget is taken up by anything to do with healthcare, so that every other thing that we like to think about, our highways, our schools, our programs all over the state, now are probably something less than 40% of what the state budget is. So there's very little flexibility right now in Boston. Steve wanted me to point out that it's not 96%, it's 96.1% coverage for people in Massachusetts. Yeah. But Steve then moved on to his deep concerns about the budgets that are being tossed around in Washington, the various plans that are being floated for healthcare and so forth. And if any of them in their current states, or even something remotely close to their current states, were to come to fruition, he sees that the Massachusetts would be in really, really deep trouble. He echoed Eliza by saying there would be a $2 billion loss to the state if the Trump Care plan as written passes. And his position is that we cannot go back to emergency room health care because that was even more expensive for the Commonwealth than the Trump Care plans that were being proposed. So he is in the process of, he is a co-sponsor of a single payer plan, and that's where Jackie will come in as well as she explains her part of this discussion tonight. It's a mass care bill that it very simply monitors the current healthcare in the state and then uses some measurements that I don't understand, but they would sort of model what a single payer plan would be while they were looking at the current plan for a 3-year period. And if at the end of those 3 years, if the models demonstrated that the single payer plan was a more effective plan, then it would convert to that single payer plan. Can this work? I don't know. Steve doesn't know, but it is the one that he has signed on to. But I will say, and this ought to make Jackie happy, is that if the other single payer plan were to make it to the floor of the House and get some traction, Steve said that he would be someone voting for that plan. So in a nutshell, that is what Steve was hoping to have said tonight. So now to make corrections on that is Mike Knapik, who's the director of Governor Baker's Western Massachusetts office. Mike is from Westfield, and for 22 years before that part of his career, he was in the Massachusetts legislature, first as a state representative and then as a senator. Michael Knapik.
Evan, thank you very much, and good evening to everybody. And I'll try not to fumble my papers here, but nobody seems to be going behind the desk there, so I won't do that either. But I want to thank Evan for pinch hitting a little bit for my good friend and former colleague, Representative Kulik, and he and I came into the State House way back in 1991, which I think was I think we were millennials at that point, but that was the old millennium. But Steve and I had a great working relationship for many years. And I know Paul from his office is here, and we had the great honor of serving on the Joint Committee on Ways and Means Conference in the last 3 or 4 years of my tenure. I on the part of the Senate and Steve on the part of the House, 2 members from Western Massachusetts among 6, helping to develop the priorities for the entire state budget. And the evolution of the budget is much similar to what Eliza spoke about with the evolution of healthcare. And I just want to say, I hope people paid rapt attention, because I actually learned an awful lot from that analysis, and it is absolutely spot on in terms of what this state did over those many years to position ourselves as a leader in health care, a leader in reform. And what I'm here to share with all of you, and I hope you know that, and I appreciate Eliza's kind words earlier on behalf of the Baker administration, the governor has made it very clear from the beginning of the change in administrations that policies that negatively impact the citizens of the Commonwealth are simply unacceptable. A state that has positioned itself as a leader in healthcare reform for really generations would obviously be victimized in a very serious way by the proposals before the Congress of the United States. So he has said in no uncertain terms it's unacceptable, and his entire team of healthcare experts, including our state's Secretary of Health and Human Services, Mary Lou Sutters, have been very outspoken in saying, we have charted a path in Massachusetts that literally, in the modern age, goes back to that time frame when Representative Kulik and a number of us came into the legislature. There was the budget at that point for Massachusetts was $12.3 billion in 1990. So what I would often say is, so from the time of the Pilgrims until 1990, the budget was $12 billion. So from 1990 to 2018, fiscal 18, which will start on July 1, the budget will be about $40.4 billion. So in that 27-year time frame, the budget is expanding, but no different than, with all due respect, municipal budgets, other state budgets, the national budget. There was explosive growth in the economy that in a state like Massachusetts allowed us to set a certain set of priorities over that generation. In Governor Baker, and I hope you recall some of his background, so Governor Baker served as the Secretary of Health and Human Services, much like Mary Lou Sutters does today, on behalf of then Governor Bill Weld. So he came in 27 years ago and managed, at that point, half of state budget, which was about $6 or $7 billion. And he helped to usher in that early part of his tenure, much of the reforms that occurred in the early 90s. He then served as the Secretary of Administration and Finance through Governor Cellucci's term, so he was the one responsible for making sure the budget balanced. And as that trajectory through the 90s grew with the state budget, expanded priorities, and all those things, moving poverty levels and moving eligibility levels and bringing on dental and bringing on more mandated benefits, the governor was part of those discussions in those years, then moved on to Harvard Pilgrim, which was a bankrupt HMO at the time, and within a number of years turned it around. And I don't say that as an homage to our governor, but to say today in this environment, as a leader of a state, a very important state, he is uniquely qualified to speak on the issues of healthcare confronting our nation. And so, he has been doing that. And one thing, and I think Eliza alluded to this, the better part of the last year, calendar 2016, was spent trying to secure the next waiver for the Medicaid expansion in Massachusetts, along with the flexibility that will allow us to make sure that citizens are covered. We're controlling spending, controlling growth, but to make sure that the federal government lives up to its bargain in the Affordable Care Act world. And President Obama granted the Commonwealth that waiver for the following 5 years. So then a change of administrations, which sometimes happens, as we know, has created another word I would share. Eliza used the word complicated. I would use the word, no, it's not your word. Eliza shared with us the word which we know, complicated, which healthcare is. The other word which which I think also describes the environment, uncertain. So we are living in a very uncertain time that seems to be ever changing by the week. And to that point, what the governor had done in the beginning of the Trump administration was to immediately weigh in on the commitments that the Obama administration had made based on what we had done here in Massachusetts over the last 10 years, both with, and I call it Romney-Kennedy care, because what you had was a bipartisan effort with Senator Kennedy and Governor Romney at the time. And I want to say out of 200 members of the legislature, there may have only been 1 or 2 votes against that bill, simply because we knew it was the right thing to do for the citizens of the Commonwealth. The 2012 law that was passed, Steve and I voted for that, was to make sure that we would continue the progress, work with providers, work with the entire network, which again at $20 billion is very complicated, but make sure that citizens could have predictable health care and that the government would manage it well and the expansion would occur, which happened under the Affordable Care Act. So none of the benchmarks or none of the parameters of that have changed in the minds of the administration. And so as the House plan came out, as the cabinet was put in place, as congressmen and women across the nation began to speak out, the governor has been part of those conversations. I will underscore, and I may be a little bit all over the place on this, but Eliza mentioned the state of Maine. Not every state speaks with the same voice when it comes to the view of health care. But the good news for the Commonwealth is there are probably 12 to 15 states like us that committed themselves, after us, but committed themselves to a model of expanded universal care based on the Affordable Care Act. We were well along the way. There were states at 80% coverage. We were at probably 93% coverage when the Affordable Care Act came in, and then the extra 4% was the efforts over the last 3 or 4 years, and then Eliza points out the 3-4% bubble that we're trying to get at, we're clawing to get at, and that's what just simply time should get to. One of the pieces that hangs out there as a cost center for the state is about $300 million that the governor's budget, the House budget, and the state Senate budget are working to reconcile how you pay for part of that expanded population when the federal monies available today don't fully cover it. So there's a challenge around that, and it's based right now on an assessment with the business community, which is not without some degree of controversy, but it's really meant to make sure that in this fiscal 18 budget, we preserve the healthcare system that has been created, that has been shared, and that all folks in both parties have embraced. So the fiscal 18 challenges are there. Evan pointed out, or Eliza did, that the fiscal 15 Medicaid budget was $13.7 billion. The fiscal 18 Medicaid budget will be about $16.4 billion. So you can see how very quickly budgets get away from us, not for want of reckless spending, but certainly because the cost of this system is what it is. And I know that leads to other conversations, but for now, we want to make sure that the system we have today is affordable, sustainable, and it requires that partnership with the federal government. So whether it's the Bureau of Medicaid and Medicare Services in Washington, HHS Secretary Price, our partners in the federal delegation in Washington, the governor has weighed in with each of them and all of them along the way. I do have some quotes which I could share, but he's made it pretty clear in letters he has sent as late as last Friday to 3 U.S. Senate committees about what this potential change in the House plan would do to Massachusetts, and any of the changes that are on the table are simply unacceptable. And so part of the role, I think, of elected officials is to keep saying it and saying it and saying it over and over and over again, because the legislative process, and Steve and I and selectmen and others know it, it's not a one and done, but it's a sustained effort to make sure that your state, your citizens have a voice, irrespective of any party affiliation. Massachusetts has done well in a very bipartisan way to advance the interests of the Commonwealth. I think the governor's pretty much shared that Washington ought to take a page out of the Massachusetts experience. We hope that they will listen, but what gives us, again, some degree of solace is those other states that know that the National Institute for Health is a critical component of providing investigation, discovery, support for our national health care system. The governor's been very outspoken on Planned Parenthood, obviously, should there be any curtailment of those programs. But the big, larger pieces of that are simply, draconian cuts to the Medicaid program that had been put in place are simply unacceptable. So as this bill moves through a legislative process, which has not worked well in Washington, a legislative process, there needs to be ample time for people to come to the table. So we also have a Washington, D.C. office. I don't know how many folks are aware that the Commonwealth of Massachusetts actually has an office of its state government down in Washington for good reason, as you can imagine, and it's very busy these days. So we have an office in Springfield and we have an office in Washington, and sometimes I say to folks, the reason we have these regional offices is because we're both so far from Boston. So here in Western Mass, and you know this, and let me just give you a shout out in homage to our 413 area code. This is an extraordinary part of the Commonwealth. You know that, and I'm viewing as the director of his Western Massachusetts office, I get to visit a lot of towns that I didn't visit when I represented much of the lower Pioneer Valley. And I've come to gain a much greater appreciation for the region that I call my home. In the region, I think while it has challenges, It's probably one of the nicest in all of New England. So that point aside, that's just for us, yay for us. That point aside, our Washington office is fully engaged with our administration. And so just by way of mechanics, and I won't go on too much longer, I hope, but we have cabinet secretaries, they have cabinet secretaries, and they work very close. Transportation secretary at the national level, we have a state transportation secretary. So they're very much engaged in developing transportation policy. We in Massachusetts are very enthusiastic about infrastructure spending and road and bridge spending that the federal government sends our way, whether it be via rail or surface transportation or anything else. So there are some very robust and good conversations going around in that world. Homeland security, cyber security, internet security. So there's a whole apparatus that parallels the state and the federal government in terms of that. So there is a divergence, obviously, on this health piece. But again, it's going to be probably a combination of those states that are heavily wedded to these waivers, to the expansion of Medicaid, and quite frankly, what I think the governor would say, and all of us in the legislature would have said, doing the right things by our citizens. So, nobody's got that crystal ball, but engagement such as this evening helps to inform you folks a little bit, and helps to, I think, motivate people that there are options out there are opportunities out there, and I'm happy to connect, and I can do it with Eliza and others, because one of my first calls today was from the food bank in Western Mass, who do extraordinary work throughout our region, and I had a chance to tour that facility a couple of weeks ago. So I connected Andrew and Michelle and Christina up there with our Washington office to do two things: create a relationship with an important agency out here in the Western region, but also to create opportunities to look for the threats or the risks or what might be challenged, so that the Baker administration in Washington is fully informed about what the consequences are. And I think that's and the woman who heads up our Washington office, wanted to have a conversation today with the folks to talk about the FMAP program. So there are robust and good conversations happening, because this helps inform the administration about the best course of action. And when citizens get motivated, it's not Governor Baker alone, or a legislative leader, the Senate president, or Speaker of the House, but they're acting on behalf of their constituents. And the quality of life in this state is one that I would like to think, and I think both governors and legislators alike would say has been created as a shared priority of the visions, the hopes, and the aspirations of the people who live within our Commonwealth, whether it's the 4 western counties or anywhere else. So I'd be happy to answer any specific questions. I actually have copies of some of the letters that the governor has shared at the federal level. He works very closely with Senator Warren, Senator Markey, our 2 congressmen from out here, but the entire delegation, who are weighing in with their colleagues on the Washington level. There's 535 members of Congress in the U.S. Senate. There are 50 governors, 49 state legislatures, 50 state legislatures, but Nebraska has that unicameral thing going on. But every state, it's not a monolithic union. Every state has an opinion as to what is happening. And I think the louder and more forceful we are, in one sense, to defend what has been created here with people of good intentions is one way that we obviously hope to succeed. So I would say on behalf of Governor Baker, Lieutenant Governor Karen Polito, we need you to be engaged in these discussions. We know there are immediate battles and longer-term things to be concerned with, but I would have to share with you that everything he has done with respect to relations on health care with the federal government has been both to defend and to support and to offer opportunities and options when asked, because of his deep and sincere background in the healthcare space. So I'll just conclude there, and happy to answer any questions you may have later on, but thanks for holding this kind of forum. And it is a beautiful night in May in New England, in Worthington, but the fact you're here, I think, speaks volumes about how much you care about this issue, no matter what the larger perspectives may be that people will have, but also what's important to us as citizens of this great Commonwealth. So thanks so much for your kind attention and letting me be here.
All right, we're getting our logistics together for when we can have the Q&A, which is coming up after Jackie Wolf will speak. Again, the microphones are on either side. Get your questions ready in your head. Jackie Wolf is the Western Mass co-chair of the MassCare, the Massachusetts Campaign for Single-Payer Healthcare, and the chair of the League of Women Voters of the Amherst Healthcare Committee. And I suspect we'll be hearing about single-payer from Jackie.
Yes, thank you very much. I'm glad to be joined by my distinguished panelist. Actually, I was going to sit up here if you didn't, because I prepared for today's healthcare by donating a pint of blood today. So I appreciate your sympathies, and I'm sitting down. I love the sun that is sitting in front of us up here. You all can turn around and take a look at it. To me, it represents, it's got to be a way forward. After hearing what Elizabeth told us and the words of Mike, it is just frightening. So let's put our minds into something that's a little bit more thoughtful or promising. And before that, I want to certainly add my thanks to Pam Thompson for inviting me here today, and Evan Johnson, our moderator, and our fellow speakers. I take a real pride in representing MassCare, which is the Massachusetts Campaign for Single Payer. It started back in 1995. I am also chair of the League of Women Voters of Amherst Healthcare Committee, and I mention this because the League of Women Voters took a position in 1993 after several years of studying healthcare reform in the United States. And what they adopted is single payer, and that's why we've been able to talk about this all around the nation. As I look at the audience tonight, I see mothers and fathers, sisters, brothers, friends, neighbors, people from all walks of life. Some of you have health insurance that is paid for by your employers. In your insurance plans, protect your health and incomes at an affordable price and give you access to a good range of benefits. Others in the audience tonight, particularly those who work several part-time jobs and those self-employed, have insurance plans which you can barely afford. They require high deductibles in the thousands of dollars, and your benefits are limited to a certain network of providers and restrictions on treatments. You might be related, you might be friends, but it is likely that you all have different plans with different premium costs, deductibles, co-pays, co-insurance, and benefits. The point I want to make is this difference in healthcare and health insurance based on income and level of employment is morally wrong. Morally wrong. Access and affordability to good health care should not depend on your level of income or your inherited wealth. Access and affordability of good health care should not depend on your choice of insurance plans by your employer. Access and affordability to the full range of contraceptive needs and reproductive choices should be your decision with your doctor and not determined by the religion of your employer. Quite simply, this is the goal of Massachusetts single payer. A quality health plan with good benefits for all, funded in the simplest and most direct way, a payroll deduction. By moving to a single-payer plan, we eliminate the middleman, the private insurance companies with their ever-increasing premiums, deductibles, their wonderful benefit levels named bronze, silver, gold, not to mention the denials of treatment plans and the wasteful and inefficient billing practices. We control costs by negotiating with Big Pharma for all residents in the states and likewise for the administrative top-heavy hospitals. Who else is talking about single payer? Let me mention two. Senator Elizabeth Warren. The senator expressed it this way in a recent interview with the Daily Hampshire Gazette when she was in town for the graduation exercises at the University of Massachusetts Amherst. Quote, "The core is saying we have made a change in America from where we were 10 years ago, and that is we've come to understand, to believe healthcare is a basic human right." The reporter also noted that a recent Morning Consult Politico poll found that a plurality of voters in the United States back single-payer health care. If politicians aren't your cup of tea and you have a more pragmatic bent, Here is what Andrew Surer wrote for Yahoo Finance on May 7th, after interviewing one of the well-known corporate titans of our day and Warren Buffett's partner. Quote, Charlie Munger says that single-payer health care is the fix to the nation's health care woes. A long-standing Republican, the Berkshire Hathaway vice chairman acknowledges it is an unusual position from someone from his party to espouse. He basically said the single-payer countries were eating the lunch of the business community in the United States. All right, let's go back to the question, what is single-payer? Single-payer is a health insurance plan. When single-payer is in place, all Massachusetts residents would be enrolled in one plan, providing access to your choice of doctor, hospital, mental health therapist, and other healthcare providers. Vision and dental care would be provided along with other medically necessary treatments. The plan would be affordable, and the payments would be collected by a payroll health deduction, similar to Medicare, which is Medicare's now. And in fact, Medicare would be rolled into the single-payer tax. It would just be one. Professor Gerald Friedman in the Economics Department of the University of Massachusetts Amherst, who has done the financing plan for the Massachusetts single-payer, estimates this payroll health deduction, this health insurance tax, would be at or less than 10%, which is what the large employers now typically pay, likely divided into an employer contribution of 7.5% and an employee contribution of 2.5%. And again, after paying the payroll health insurance deduction, we would not pay any more health costs. No premiums, no deductibles to meet, no copays, no coinsurance. With a single-payer plan, healthcare providers would be paid in a timely fashion. There would be careful attention to how well healthcare providers were meeting the needs of patients. There would be a feedback loop, and whether there was access to needed services across the state, a sensitive issue, as Elizabeth mentioned, for those of us in Western Massachusetts. Single-payer is a tested and proven approach. It is a tested and a proven approach to delivering quality health care. The major developed countries of the world, Germany, France, the United Kingdom, Japan, Taiwan, Canada, and many others have used a single-payer approach for decades. The mortality and morbidity statistics of the single-payer countries I've mentioned show better outcomes than the United States. These countries have also been able to control rising healthcare costs at a lower rate, all the while providing quality healthcare for everyone in their country. We have a good example of single-payer in the United States, Medicare. Single-payer is also known as Medicare for All because the two concepts are linked. Just like Medicare is paid through payroll deduction, and just as Medicare gives you access to your choice of healthcare provider, single-payer would do likewise. I'm going to digress a moment and ask two rhetorical questions. You don't have to answer them. Who in this audience who carries a Medicare card would like to come forward, tear up that card, and go back to the private health insurance, poring over their gold, silver, bronze benefit levels, paying ever-increasing premiums, facing higher deductibles, rising copays practically every year? And the second question, how many of you have older relatives, grandparents, mothers, fathers, sisters, brothers, who are so thankful that they carry a Medicare card? How many of you know loved ones who would be either in poverty or on the brink of poverty, paying their medical and drug needs were it not for the Medicare system enacted in this country in 1964? I pose these questions to show you that you know single-payer, and you know how important it is. Single-payer is Medicare for all ages. Why do we need single-payer in Massachusetts? In addition to the moral point that I raised, Massachusetts cannot afford the health care costs of the state. As Evan reported from Representative Kulik, health care costs are running at 42% of our state budget. And that's just the prominently named, the explicitly named cost. As Representative Kulik gave the other number for Evan to report, when you add all the other areas of healthcare cost spending, for example, the healthcare for in correctional facilities, it comes up to 60%. 60% of our state budget going to healthcare costs, and we can't control the rising cost. Healthcare is sucking up money that the state could spend on education, transportation, safety, and any number of social services which are badly needed. In addition, healthcare costs are taking a larger and larger portion of our household spending. Back in 2015, Massachusetts households spent 17% of household income on healthcare, about $12,000 per person. This figure includes insurance premiums, copays, deductibles, out-of-pocket costs. It doesn't have to be that way. It doesn't have to be that way. Let's move to single payer in Massachusetts. What do? The Act to Controlling Healthcare Costs and Providing Quality Care for All is detailed in the Massachusetts Bill S619 or H2987 entitled An Act Establishing Medicare for All Massachusetts. On your chairs, you saw a stapled together handout, and the blue sheet gives you the name of the bill and a brief summary. S619, which I will call by the shorthand the single payer bill, would generate a savings in the neighborhood of $18 billion. It accomplishes this by eliminating the administrative waste and inefficiencies in our present health insurance with multiple private insurance companies. These private insurance companies have overhead rates in excess of 30%. Compare that to an overhead rate of 1% for Medicare, and Medicare covers 55 million Americans. Doctors tell us all the time that the denial of treatment plans by the private insurers is an obstacle to delivering good health care to their patients. They don't want it. Not only would the state save close to $18 billion, and I must admit that figure does include federal monies, which who knows if that will be there, but let's say it would at least save, what, $17 billion if we take out $1 billion? The Massachusetts residents would also see savings as their health insurance costs would come down. In a recent article in the Valley Advocate, Dave Astetter cited Professor Friedman, who calculates that a typical family making $50,000 a year would save an added, would see $500 added as a part of their health tax, their payroll deduction. Their savings would be $6,300 in premiums, deductibles, copays, coinsurance, which gives you a net savings of $5,800 per household per year. And the same Valley Advocate article pointed out that employers would benefit with a savings of $9,500 per employee. I want to repeat those numbers because it is important to understand that individuals, employees, as well as the state will save. And we've got to stop being hoodwinked when people say, single payer is a tax. You're going to be taxed. It's an expensive tax. What you've got to stop and say to yourself and to this other person who's trying to scare you is, tell me about the savings. Tell me about the savings. In Massachusetts, that $50,000 a year household would save approximately $5,800. Finally, Massachusetts is not ahead of the curve moving to single payer. It's behind the curve. The New York Assembly has already passed this bill twice, and they are right now 2 votes short in the Senate. Recent emails suggest they've got that 1 vote locked up. They've got 1 more to go. Andrew Cuomo a couple of years ago said he'd sign it as soon as it came to his desk. We'll see. California has passed it twice in their House and Assembly. Governor Schwarzenegger vetoed it twice. The single-payer movement in California is revving up again, and we're hopeful that Governor Jerry Breaker will sign it. All right. In fact, single-payer legislators are all over the place in many states in the country. What can you do to get involved? And we'll wrap it up here. Here are the steps I suggest. Talk to your family, talk to your friends, talk to your neighbors, talk to everybody in Worthington and everybody in the 413 area code that you know. Let them know you're interested in single payer and encourage them, if they don't know about it, to sign up for MassCare or sign up for the Valley Action Network email list. There's a clipboard on the table over here, and get information. Speak to your legislators. It's wonderful to hear that Representative Kulik has already signed on to the benchmark bill. That's the small bill that compares the costs of the actual healthcare spending with a single-payer model. And if the single-payer model is proven to be as good as we say it is, and we have confidence that it will, then the state would start the transition. Also, look at the green handouts on your stapled packet there, and look at the actions that you can take. Write Senator Welch of Springfield. If you know him, go down and visit him. If your family is there or your friends are there, if your labor union buddies are there, ask them to stop in and talk to Senator Welch. He is co-chair of the Joint Committee on Healthcare Financing, which is where the single-payer bill is headed for its hearing. On the House side, it's Representative Jeffrey Sanchez of Boston. He really needs to hear from single-payer people. If you know anybody in his district in Boston, please tell them to call him. But you're welcome too. Isn't it right, Senator Knapik, former Senator, that the representatives in the Senate, they do have to listen to their constituents, but all of us can talk to these folks, and it's extremely important for Representative Jeffrey Sanchez to hear from you. And I would then finally say, connect with MassCare and other organizations working for single payer. I want to thank you so much for listening.
Thank you, Jackie. That was wonderful. The floor is now yours. The evening is now yours. There have been tons of questions thrown around, tons of information thrown around. Eliza got our head spinning early with lots of facts and figures. Somebody must have something that they would like to ask of this wonderful group of people we have up front. Mark is heading to the microphone.
So it seems like two separate worlds here, right? It seems like what Eliza is talking about, what Governor Baker's talking about, is very different than what Jackie's talking about. Can these worlds meet? For example, what would Governor Baker's reaction to be should a single-payer bill go through the House and Senate and arrive on his desk?
Yeah, so I probably can't speak to that because it's more of a theoretical and a hypothetical at this point, and I don't think it's even on the agenda. I think, you know, what he's doing now is trying to preserve the system that has evolved, you know, warts and all, that's provided a level of health care. There's no question the affordability piece, which is the reason that 2012 legislation was enacted. It's one thing to offer accessibility to health care. The affordability piece is obviously the greater challenge, which is why that federal partnership is so critical. So it's sort of the immediate battle that exists today is the one about the healthcare system that is ensuring 97% of 6.5 million citizens. So I think that that's where the governor's putting his energy at this point. And I think I will say this, and I know I've had briefings over the years, it's a very intriguing discussion that I think resonates in a different way today, perhaps, than it did some decades ago. But I think, you know, the governor and his team, and even the budget of the legislature right now for fiscal 18 reflects the system that we have and making sure that, you know, that doesn't fray any further than it may be perceived to be fraying.
people forget about the overhead costs. These executives, the insurance companies make obscene salaries. I'm sure nothing like Eliza makes. Also,
Yeah, could you speak right directly into the microphone? I know it's
thank you. The overhead, every doctor, you don't see many doctors in private practice anymore because they all have to have somebody from an insurance agency to take care of their billing. That's why having multiple insurance companies is not to the advantage. That's one of the things single payer takes care of. Yes, some people might lose their jobs from an insurance company, but they're not going to, they can also be picked up by the agency that is taking care of billing. And these salaries of these insurance agencies and are available, and I'll tell you, they are obscene.
Thank you very much.
So I have a question about the percentage, with the single payer. With all the research that's been done, are there statistics about what percentage of the actual medical community would be involved in that system? Is it every medical professional can be involved? Is there still, I'm trying to understand kind of where the private practice versus, is it a universal health plan that every single medical professional in the United States is involved with and gets reimbursed through? What's the other side of this? I mean, we talk a lot about what we need as individuals for health care, but where are the medical professionals in all of this? Is there still going to be a percentage of medical professionals out there that are going to say, I don't want to be part of that system. I still want to have a private practice. Where does something like that play into making this happen?
Okay, it's a complicated question. Use that word again. If we're talking about Massachusetts and how the Massachusetts single-payer bill is structured, which is like to the New York bill, all healthcare providers who are licensed, so you need to be appropriately licensed by your professional board, have the opportunity to, and who want to practice in the state, would be eligible for payment. Now, you could opt out, sure, but you would not be eligible for any payment from the state trust fund. All bills, the power, the efficiency is that all bills, whether you're in private practice or community centers or mega hospitals, all bills would go to the single trust fund. I hope that answers your question. The other thing is that might be part of it is that there are variations of different types of single-payer combinations in the countries that I mentioned. And some have a little bit more of a private insurance piece than others. Every one of the countries that I mentioned fashions its single-payer plan to resonate with the cultural values of the people. And the example I like to give is that in Japan, their single-payer plan includes 12 days of rest and relaxation in a care center. For no good, not for any good reason, not no good reason, but for any good reason, If the kids or the dogs are just tearing your hair out, you can check in and it's paid for. We probably won't do that here in Massachusetts, the home of the Puritans, but that's what I say about how it resonates with the different cultural values. Also, one should say that the bill talks about all medically necessary and all preventive health care needs. If it's what is known as purely elective surgery, like straightening your nose that is not as a result of an accident or some other type of congenital malformation, but maybe you want to look like what Barbra Streisand looked like, if those people in the audience remember Barbra Streisand. That would not be paid for.
Is that microphone on?
I think it is.
Excellent. I was going to say, I'm assuming everyone heard about the town in Norway just last week who was looking to get a 3-hour per week conjugal visit section in their health care plan, but it did not pass the local legislature.
So can we bring it up again now?
Yeah, absolutely.
2 points I want to make, both for and against risk pools. I just retired from 50 years of working with catastrophically disabled people, with spinal cord injury and brain injury and big burns and multiple amputations. And the problem with putting people into a risk pool that is a carve-out from a larger insurance policy is that that makes that group an easy target. When you talk about trying to control costs, the first thing you do is look at all those people with spinal cord injury and brain injury and autism who are never going to be the kind of wage earners that we think should be covered by the benefits of health care. It makes them a target. We've just spent 30, 40 years trying to integrate people with special needs into the mainstream, and I think this is just a way of putting a target on everybody's back. Because when it comes time to cut, it'll be the folks that are the most vulnerable that'll be cut first. On the other hand, I talk in support of single-payer health care because that is the ultimate risk pool. That's where everybody's in, all in, and because it's not a carve-out, it works because it spreads the risk among all of us. So on one hand, risk pool good, on the other hand, risk pool bad. But the way it's been proposed in the current administration, I think this really takes us back 30 or 40 or 50 years when people with special needs and long-term disability were basically kept at home or institutionalized because they weren't worth as much as the rest of us. Thanks.
I just want to make one comment about that, and thank you for that comment. And coming from the disability rights movement as sort of part of my past, I really appreciate that. And what it reminded me of, and so I mean, literally, I feel like I'm reading the news 10 minutes before this starts, trying to keep track of everything that's going on. But one of the things that I was interested to read today, and we haven't talked about Medicare at all. But according to what I was reading, and I think it was in the Times, the president's budget didn't talk about Medicare at all. Didn't touch it, absolutely not at all. But what they're reporting is that Paul Ryan is still saying that he believes in voucherizing, if that's a word, Medicare. And I think that, in all my health policy classes, I think that there's sort of this conversation about one reason Medicare should always not be related to income at all is as soon as you bifurcate a policy like that between the haves and the have-nots, then you create a political opening for making that division even greater. And so I think that that's a real concern. I mean, there's a number of concerns about changing Medicare as it is now, but I think that's definitely one of them.
Can you hear me?
Yeah.
Okay. I have a couple of questions. You brought up Medicare, and there was some money coming from Affordable Care Act toward Medicare. I'm not sure how that worked, but to people that were missing certain part. What do they call them?
Yes. So the Medigap.
Medigap, right?
Mm-hmm.
And so I wonder how. Do you see anything in this new bill that's going to continue that?
Pardon me? Yeah, I don't. So for those who are not on Medicare pays for 80% of the costs. Even when you have Medicare, it does not pay for all of your health care costs. And so people are nodding. You probably know about this better than I do, but John certainly does. And so you can buy a Medigap plan to cover that 20%. But I don't believe there was anything in the ACA about Medicare.
The only thing I saw in the ACA...
Take the microphone right there.
Sorry. The only thing I saw in the ACA was in regards to Medicare Part D plans, and that donut hole is supposedly eventually disappear.
You gotta put your mouth right on it, John.
Okay.
Close, close, close.
Okay. Basically, what they were looking at was the donut hole within Medicare Part D, which is your prescription coverage. Okay. That was eventually supposed to disappear by 2020, I believe, in increments each year. And we've seen some progress there. You know, Medicare, we talk about a single payer system, but, you know, like Eliza says, it only takes care of 80%. There's the Medigap piece or Medicare Advantage, and then there's your prescription coverage. So, you know, for some people, that's hard to deal with too.
What?
Okay.
Well, what he was saying is that, I mean, he was reiterating that Medicare does not cover the whole thing, but also that there's this donut hole, which my understanding is that in Medicare Part D, you're covered up to a certain point, and then there's a period of time when you have to pay out of pocket before your coverage kicks in again. And the ACA addressed, you know, was structured to address part of that hole.
You had a second
Actually,
question?
well, can I just jump in? I am glad to have gotten this, you know, what I'll just generally call as a reminder. When I say Medicare and single payer and they're the same thing, Medicare recipients in Massachusetts would move into the single payer plan, and the single payer plan would cover all the expenses. So there would be 100% coverage. There wouldn't be a hanging 20% gap. Thank you for.
The other question was those of us who have health insurance beside Medicare, how does, like, what happens to those things? Like, my husband has one that comes from, through his union, his international union, so it's not inside Massachusetts. So how would you plan to deal with, and plus Medicare takes out so much money from Social Security for your payment. So how would all of that gel with single payer?
All of the monies for the healthcare trust would be directed into the one plan. And part of the operationalization of single payer would, on one hand, require the federal government, through the waiver issues, to allow Massachusetts to collect the Medicare monies, if there's any Medicaid monies, all of these. And all of the other programs, the insurers, would also, money that is coming to a person would be directed into the trust fund. That's a little bit different than, let's say, you know, it is, the concept is one in which, again, there is one trust fund and not multiple different. In Canada, for example, all of the Canadian residents, no matter where they get their money, you know, their benefits from previous to 1964, it was all consolidated. And so there is only one major trust. There are fringe areas in which things are collected. Again, there would be available private insurance if you wanted to carry that for certain types of issues. I'm not exactly sure. Again, cosmetic surgery is the usual example that comes to mind. But the power of the trust is that it does have all the monies for all these things, but it has to be operationalized to get that.
It's a little hard to keep track of everything because it's like changing so quickly. But in the last week, they've been talking about cutting SSDI. And the people who are on SSDI get Medicare. So they are talking about screwing with Medicare, basically, because they're talking about who's going to be qualified to get SSDI. So there'll be all these people that'll be pushed off Medicare.
Yeah, I don't know. So SSDI, for those of you who don't know, is Social Security Disability Insurance. I have to say, I personally haven't read the details of that. I understand what you're saying, that if you're eligible for one, you're eligible for the other within, if you're you can qualify for Medicare not just on the basis of age, but also on the basis of disability. So I don't know, and I don't know how much detail has been published about whether what they're going to delink those eligibilities, and this is just focused on the income piece, the SSDI as income payments versus SSDI as your eligibility for being on Medicare. I don't know. I don't know if anyone else knows. John, I don't know. Beulah May, do you know?
What I saw was basically income, but
right.
But in the next breath, it's like the block rates for Medicare.
Right. So I mean, I think that that language was included in the president's budget in terms of thinking about the social safety net, not including healthcare. So it's really just those income payments. But I really don't know.
But if you're not getting SSDI because they won't let you on, then they're not going to say, oh, we're going to give you Medicare,
Well, but they could maintain the eligibility process for Medicare for people with disabilities separate from eligibility process. I mean, I'm totally guessing here. But they could create an eligibility process that is distinct from the eligibility process for Medicare, is my guess. But I'm trying to read into the mind of the president and his people, so I don't know.
Yeah, I guess, I guess I'm a pessimist when it comes to these things, so.
I have a question about the single-payer program and how it might relate to employers that are currently exempt from having to collect Social Security tax, and would the new proposed program require them to do that, such as the state and a lot of the towns that have teachers under that program that allows them to retire on a teacher's program rather than a Social Security system and get GIC insurance rather than Medicare?
Are you asking whether or not the retiree would be paying
into the pool, or would the employer, the state, be exempt from it?
For active employees?
Yeah. Yes,
for active employees, it is a payroll tax. There is a $30,000 exclusion. The first $30,000 of income is to be excluded to make it fairer. So some of the calculation is, if, for example, you have an employee who has a $50,000 income and you exclude the first $30,000, it's a 2.5% tax on the next $20,000, and the employer pitches in 7.5% on that $20,000. When the person retires, there's no further tax, health care tax on retiree benefits. There is no tax on Social Security. There is no tax on any type of pension. There would be a collection on dividends, interests, and rents, excluding the first $30,000. That's the financing plan that Professor Gerald Freeman has developed at this point for Massachusetts. It will likely, it's a moving target because of whatever happens in the Massachusetts budget or with the federal budget, but that's the plan that we have in the bill now. The New York plan is very similar with a little bit of a different. The percentages are a little bit of a different level. Does that answer your question?
As a follow-up, then, I guess I'm a little unclear at the state level what the plan is for those employees that don't pay Social Security tax now because they're not going to get Social Security when they retire. But at the federal level, I know that from a retirement plan, the Congress has a special plan. Will they also have a special option to not be part of our single payer plan if it ever gets federalized?
What a dream. I can't answer that hypothetical, but thank you for the question.
Hi, I have a two-part question with a short story in between. So the first question, I think that all of us here have such varied experience with health insurance, and what we know really informs, maybe what we think should happen. And so my first question would be for Mike, what do all, legislators and people who work in the government, do you all have a particular kind of shared health insurance in Massachusetts? I'm wondering what it looks like for you, what your health insurance is.
Yeah, so much like so there's the GIC is the Group Insurance Commission, which manages our healthcare system in the Commonwealth, and it covers those that desire to be in that system, and it parallels a lot of the other private company plans in that you've got you could have obviously a family plan, single plan options. You have an indemnity plan, most expensive option. You could have a PPO, an HMO, so you have that bifurcation. The taxpayers in the part of the Commonwealth pay 25% of most employees' premiums. I'm sorry, the employee pays 25% of the premiums, and the state budget picks up through the taxpayers of the Commonwealth the other 75%. There was some difference on employees hired prior to maybe 10 years ago. There's 20% for some, 25% for others, paid for by the individual. But that's sort of how the plan has evolved. That answer some of that? I mean, no, it's an interesting start, and so I think can you hear? Okay. So, I mean, that can I be part of the GIC? I mean, it sounds good, but
except for I'm also in the GIC because my husband is a University of Massachusetts employee. So it's a private insurance market. It's not a single market. As Mr. Knapik said, as Mike said, you have 8 different plans there, right? And 8 different levels of, it's the same thing as what other people have. The one difference is the Group Insurance Commission does bargain for all of the state employees, so there is supposedly some break. And Dolores Mitchell, the former director of the Group Insurance Commission, says that, she would definitely go to single payer.
So the second part of the question just requires a little story, which is just to say, my own experience with health insurance, and I think it's important and illustrative, so bear with me. For many, many years, I worked for a small publisher, and we had the most incredible health insurance kind of in the world. I would go to doctors and they would say, "You have a $5 copayment? What is?" Anyway, it was Blue Cross Blue Shield, one of the biggest insurers in the country, and gradually every year, you all know this. I mean, it would go up like 50%. But then it became, interestingly, they were trying to convey to this small little publishing house that there could be no health insurance that good. So one year, finally, in the end, the health insurance went up like 600%, because they were just trying to make that plan disappear. So, that's in the past. It was incredible health insurance, and it's what our family sort of grew up with, and it's what enabled you know, our kids going to the Worthington Health Center. It's what enabled, you know, our son, who was incredibly ill in a way that could not be addressed at Cooley Dickinson or Bay State, and had to go to Children's Hospital in Boston. You know, all these normal things that, you know, happened. Now, what our family's looking at is just a really simple thing, which is getting coverage, connector care. And what I'm noticing that for anyone who's doing that in Western Massachusetts this year, you can't do these things that we've done in the past. Like, I couldn't, you know, break my arm and go to Cooley Dickinson because that was the closest hospital, or also go to Bay State if that's the place where they had the dermatologist who was going to, or, you know, maybe have to go to Dana-Farber because I have some rare kind of cancer. Like, that is now not possible with those healthy, like, you can't go, you have to choose one of those hospitals. Yeah, so, I mean, and it's true for, but, you know, I'm just mentioning connector care because that's our sort of joint project, you know, that's what the state is offering. So I guess, you know, that's a big, this is why we have to do something. But my direct question for you is just like what you can say about really how this marketplace has narrowed our options so incredibly, so that now, you know, this incredible array of hospitals, you know, like if you have a hospital, if you have a heart attack in one, like you can't then be moved to Bay State. You know, there's just, seems like a crazy disaster. What is going on between Cooley and Bay State? I mean, can you guys speak to that, for example?
So, I guess in the spirit of full disclosure, I have to say that I am a trustee of Cooley Dickinson Hospital. So I just have to say, which I just have to say that because I think it is a public fact. So I think, so my go-to place is always to get big picture. Our healthcare system, which was created during World War II, was employer-based at that point because it was a way of getting employees, when there were very, very few of them, to go work at a particular company. So the companies created Blue Cross Blue Shield in Texas because it was a way of getting people to come to get employees. This is why we have a completely different system than the rest of the world. One of the reasons. Till the 1980s, having a purely fee-for-service system, which means that the more services you provide, the more you get paid, created a terrible incentive for more and more and more healthcare. The more healthcare you can give people, the better, because the more money you make. It created totally perverse incentives in terms of healthcare. In the 80s, we all know they tried HMOs, but they sort of tried to reverse it, and it was a disaster for the patient's perspective. I think now we are in an era where, as you've heard over and over and over again, we're trying to control those costs. We're trying to rein in a system that was created with the wrong incentives. And so what we're seeing is consolidation of healthcare systems. You know, we are a very small player in the healthcare world, and more hospitals are buying up medical practices, hospitals are buying up hospitals. You know, Cooley Dickinson is now owned by Mass General, which is owned by Partners. And it means that there are businesses that are making decisions as businesses, as well as trying to provide care. So the interaction between Cooley and, I mean, Cooley, first of all, is a very small hospital. They can't provide, they don't have the volume to provide the types of services that Bay State can provide. So there are services that somebody goes, like, well, in fact, all of Western Mass, if somebody has a heart attack, they go to Bay State because it has the facilities to deal with that. There are examples, and John and Beulah May certainly were dealing with this, where Cooley Dickinson would contract with one insurer and Bay State would not. And we went to the state and said, look, there is a network adequacy issue that if somebody goes to Cooley and they need to see a specialist, now they have to go to Boston. And that is crazy. And, you know, we do our best. But they're two businesses who are negotiating on their own. It doesn't have anything to do with the state. It doesn't have anything to do with the providers. It is the insurance company and the hospital negotiating. And this, you know, and this is not a great answer. But I think the costs of healthcare escalating so much means that we're now looking at we're at this, even without the changes in Washington, we are at a pivotal moment in healthcare in terms of how do we control costs. And an example of this is 2 years ago or 3 years ago when the new Hep C medicine came out that costs $150,000 a year for treatment but saves people's lives. The insurance companies, a bunch of them almost went bankrupt because suddenly they're covering a pharmaceutical. They have we can start fighting at the pharmaceutical companies too. If you can't control the cost of the pharmaceuticals, the insurance companies have to pay this, and it destroyed their bottom lines in 1 year because they were paying out millions and millions and millions of unanticipated dollars for a drug that didn't exist a year before. And that was the piece in my slide, talking about medical advances and public health crises, the flexibility in the system needing to respond to that. So, there isn't I don't think there's an answer to what you're asking. It is not a perfect system right now, obviously. I will say I think that it is, as Mike said, the system we have at the moment, and we are in a moment of crisis in terms of what might happen. And so for me personally, my focus is on protecting this incredible coverage and access that we have in the state right now. And keeping your eye on that long-term goal is really important. But but if we get too focused on dismantling the system we have, there are enough other people trying to do that right now that I get worried about how do you balance those two things at once. So I'm sorry, I don't know. Does anybody else want to?
They're all staying away from the microphone. Go ahead.
Yeah, my name is Chris Flory. I practiced primary care internal medicine for over 30 years in Northampton and Cooley Dickinson also. I wanted to answer one of the questions. Somebody asked about sort of networking in primary care doctors if there were a universal health care system. I prefer universal health care because of the next question I'll bring up of do you take away what they've got? If single payer or universal got in and was effective, you can't make money as a primary care doctor unless you have patients. Enough patients would sign up for it that the networks would become adequate very early. You could force doctors to do it. That hasn't worked very well in other Medicaid situations, but most doctors would join, and in this area that has not been much of a problem. And that really applies to what was just being said about networks of hospitals. Again, you've got to have the patients. If single payer succeeded, the hospitals would have to join it, and a lot of these problems of hospital systems fighting would go away. Cooley Dickinson and Bay State have obviously had a long history of conflict, and the affiliation with Mass General was a very preferable thing to affiliating with Bay State. It will work better in the long run.
One thing I'll say about the networks too, I do think that we probably wouldn't see, I can't imagine we'd see it that much in this area, but one thing I can imagine is if we go to a single payer, although I have to say, I like universal healthcare too. I had a policy professor who said, single payer, you sound alone and it's expensive. He's Alan Sager, a very, great professor on this. But anyway, I do think what could happen in other states, in like New York or in downtown Boston, is you get concierge care, where you have docs who say, you know what, I don't want to be involved with you have it now. I don't want to be involved with any of this system. You pay me a lot of cash, I'll do whatever you want. And so we might get some sort of separation for the super wealthy not being involved in this system versus everyone else.
Yes, and as you say, we do have concierge, we have practices now. But one small statistic that I'd like to share is that Massachusetts, a couple of years ago, Massachusetts General Hospital was pointed out they have 450 people in billing and collecting. A comparable size hospital in Toronto, Canada has 2.
I would say at the health center we have 4 or 5 right now, just for a health center our size. Right. So it is a huge.
And the doctors in Massachusetts are paying on average $70,000 a year for billing and collecting it, and that's $70,000 a year before they hire the first nurse or the first clinician, or it's extraordinary.
Head right up to that microphone quickly.
Is there any way to find out the breakdown of medical costs? Like why is it so expensive? Like where the line items? I would sort of be interested. I mean, I work in a healthcare system, so I'm very familiar with healthcare. But I just want to see, like for the state, like what everything is costing. Is there any way to see that?
The only number I know off very personally is that primary care, your PCP, the doctor you go to, is 4% of the healthcare
I'm sure that
system. And so the idea is if you spent just 8, imagine how much money we could save on the other end.
But there's no other
argument.
Numbers?
I
That's
don't
it?
know.
4%?
No.
Is all we know? No, but we don't know the other numbers, like hospital administrators, insurance companies,
Yes,
blah, blah,
yes.
blah, blah, blah.
There are several, and this is Dr. Corey at Mercy Hospital. There are 2 commissions studying healthcare costs, and perhaps Mike can talk about that. One was established by the governor's office, and the other by the legislature. Now, why there are 2? Again, multiple healthcare cost assessments, but they are supposed to be developing and looking at all of these cost lines because we are in a crisis.
Yeah, so I would add, I mean, the collection of modern data for the system available, I mean, it's in the most innovative state in the nation. It's not just Massachusetts. We still have a long way to go. So the legislature, both through the 2012 law and in recent actions, are doing deep dives everywhere. So there's actually more hospital and more healthcare data available. It is online. I mean, I don't know the website offhand, but through mass.gov, you can get to some of the agencies related to the connector, the Health Policy Commission. There are reports that they put out. By way of just the chronology of time, in 1990-91, that time frame when Steve and I began in the legislature as millennials, there were about 120 hospitals in Massachusetts. Today, there are maybe 70. So the contraction of the system for a variety of reasons, including medical advances, technological advances, and things like that, has also played a role. And so there are other things that are concerning, and that's why I used that phrase earlier, our system as it exists today, warts and all. In the ACOs, the Affordable Care Organizations that are being created, particularly through Medicaid for the elderly and others, are designed in part to shift the level of care to the most appropriate setting, which will be very interesting to see how that happens, because a procedure at a low-cost hospital like Noble and Westfield is very different than one at Bay State. And yet the government can't mandate yet where you go, but through the incentives that are now within the system, which is also part of the federal waivers, part of the programs that we've embraced, are designed to have the larger clinical hospital type settings, deliver the care that is most affordable and effective, make sure that there are the appropriate number of doctors, which also gets to the issue of the, real quick, the health centers like Eliza runs and how powerfully important those are as a reducing cost kind of element. And sometimes people lose sight that, and again, the statistics I think are important to reiterate, particularly in an area like where I live, which is more heavily hospitalized than healthcare provided in terms of clinics. But I just kind of offer some of that. But so there's more data coming. Real quick, they just did an analysis on the cost of hospitals. Just came out through the Price Variation Commission. That's Jim Welch's. Senator Welch from Springfield oversaw that. So where are the high cost providers in the hospital arena? That's now actually the highest cost hospitals on Nantucket. The lowest cost is actually Noble and Westfield. And the variation between them all creates very much a sustainability problem. How do you keep them? But how you transfer resources from one element, is extraordinarily difficult. But just having that data available in 2017 for the first time is extraordinarily enlightening. I know that when it...
So this is what I wanted to talk about is the transformation that I'm talking about in healthcare right now is a real shift towards looking at quality and looking at outcomes. And so what we're actually seeing is not that we need to hire more billing staff, but the number of uncompensated people we have to hire to track the quality data that is really important to collect, to understand what is high quality care and what is cost effective and how do you prevent bad outcomes. But the burden that that's placing on the healthcare system right now, I mean, it's sort of a good thing. We want to know what's effective, but it's incredibly labor intensive. And so I think one reason you're seeing these consolidation of systems and small doctors' offices letting themselves be bought up is because it is so expensive to have those people crunching all that data that it's easier to have a bigger system that's doing that. So we've joined an ACO, an accountable care organization of just community health centers in the state, with the idea that health centers who have the same mission will have collective staff to look at that data, to analyze it, and to help us identify who are the patients that if we intervene at point X, we can save a ton more money and come up with better outcomes than if we intervene at point Y. So, I mean, that I think is, we talk a lot about the costs of healthcare and billing and insurance, but there's also the cost of getting away from a fee-for-service system that doesn't have the focus on quality.
We have gone over our time a little bit. We did get a late start. I just want to get a sense from the room. Everybody's still interested. There are at least 3 more people who would like to ask questions. Everybody okay with that? I think you've been standing here the longest. Did you have a question?
My comment was that we've heard the term that healthcare has been in crisis many times. And with the Affordable Care Act, it's my understanding that there's a real good chance that it won't survive simply by executive changes that have been made, like the reinsurance for insurance companies if they overpay, or the taxes that were taken off of the high income. If the Affordable Care Act doesn't survive, if these other acts don't get passed, is this truly a crisis, or will we just kind of stagger along like we haven't done in the past? What is your feelings about this?
This is where I wish Steve were here. I would say that that there are a lot of decisions that are going to have to be made about what do we prioritize. And so I'm just talking in this state. I think Massachusetts, if Massachusetts said we want to have our healthcare system be the same, I mean, this study that I put out says, well, the state will just have to raise another $1.9 billion, and then they can make it whole. Which I read that, I thought, wow, that's one scenario I didn't see anyone running. But I suppose it's possible. I mean, I am always sort of Pollyanna-ish that I don't think that the politicians will actually do these things. I was a little surprised that the House did pass the bill that they passed. The Senate said it was dead on arrival. But then David Leonhardt yesterday was saying, yeah, but the Senate's doing it in this closed room, these 13 white men, and they're probably going to do something very similar. I don't know. So, I mean, I think this is the problem, is none of us really know what's going to happen, but it could be really bad, or it could not. And I tend to think it won't, because I tend to believe that the bureaucratic system is designed not to have massive changes like that happen.
So Liza said that. I'm glad she said that first. I mean, I don't want to be Pollyanna either, but I mean, I'm somewhat idealistic still, but I want to fall down on that side of things, but it takes an incredible, this goes back to the diligence. It's not just saying it once to those folks in Washington, but it is a constant refrain, not just from the governor, not just from legislators. And your congressmen, we have men out here, but the congressmen and women in Massachusetts need to be fortified in what is important to the citizens of this state. And as I said, I mean, the union is made up of 50 independent states that are not monolithic in thought, in options, and opportunities. And so yet in Massachusetts, we've created this system that has served in general the citizens fairly well. It's very expensive, but fairly well. And until something else, comes along through a lot of other diligence in the legislative process, that's the one I think we are committed to trying to preserve. That said, Eliza mentioned the 13 folks that may or may not be working on that Senate bill. There's 100 states, U.S. senators rather, who represent those 50 states. They have varying opinions, Republicans and Democrats alike, at what their state's healthcare plan should be. And it didn't just start happening on January 20th, 2017. but in their own states, it's been the evolution. So that's why, I go back to, the governor is engaging governors in states like this, which are the usual suspect states: New York, New Jersey, Connecticut, California, throw some more out, Minnesota. Oregon. No. They're very high population states, high quality of living states. And again, if this is a skirmish at this point in time, they'll all be engaged in that effort as you go through this legislative process. The House has a bill, the Senate has a bill. What do you think the compromise is going to be, and when do you think it's going to come? And I know somebody said, I think you mentioned earlier, what if the compromise or monies aren't available for Massachusetts in the short term? Well, that's a different discussion as part of the budget, but I don't think there's any state in America that could absorb the kind of cuts that either of those bills may propose. We don't have $2 billion kicking around. And one thing I'd say, and I feel very badly for my former colleagues, that $40.3 billion budget is growing at a fairly modest rate of about 3.6 or 7%, which is not out of the range of moderate expansions. The revenues are coming in at less than 2%. So what do you do there in this deal? So this creates that challenge with anything that goes wrong on a budgeting process.
And I would just say, I want to reiterate that we have a congressional delegation that is very supportive, but by hearing from us, and I want to give a shout out to Jenny Gearing, who's not here right now, but she lives in South Worthington, and she wrote a piece that was published in Slate that Elizabeth Warren read on the floor of the Senate, and that was in a publication that the congressional delegation put out about the ACA and defending it, about her personal story. I think those stories, if our congressional delegation has those stories, they do have good relationships with a lot of people, colleagues across the aisle even. Elizabeth Warren, I know, is has good bipartisan relationships with Orrin Hatch and various people. And so it's really important that we continue to reach out to them. But if you have friends who live in Maine, West Virginia, where's Cassidy from? Louisiana, I think, and Alaska. Those are 4 senators, Murkowski, Collins, Cassidy, and I can't remember the one in West Virginia's name, that everyone is talking about as being the ones who could kill whatever it is the Senate comes out with. And so they're the ones who could potentially, we only need 3 to stop whatever that bill might be. And I'm not speaking about this, I just have to be clear. I work at a nonprofit. I am not speaking about the political, about this politically. I'm talking about this in terms of advocacy for policies that will be harmful to the people that we serve.
All yours.
Okay. I think you just answered most of my question. But are we mandated to follow, is the state mandated to follow the federal program, going back to the state program that we had previously, whether it be single payer or not? Obviously, the state can't afford it, but are we mandated to follow the federal, or can we just say we don't care what they pass?
My sense is that because of the states' rights move, that a lot about the AHCA is focused on states being able to do what they want, and that Massachusetts could preserve, I think, the majority of what we have. Massachusetts could sort of roll back to what we had. The problem is as you say, if the funding's not there, it's kind of hard to do that. But I don't know if you have, if the new...
No, and so I would say to that point, I agree 100%. States do have incredible rights in this federalist system, but they also go by what's called the golden rule. He who has the gold rules. So when Washington holds an enormous piece of the purse strings, the entire Medicaid program is, a lot of it is nursing home care, as I think folks know. The Medicaid reimbursements and whatnot. And half of it, it's actually, you saw the statistics, some is 88%, some is 60%, but half of it comes from the federal government. If we don't do what they want us to do, they could withhold that entire amount. And that's half of $17 billion. So how do you operate anything on that? And again, I offer much of this, certainly, we've moved apart from, certainly some of the initial parameters of what we're talking about, but we're having a very robust conversation at what's at stake and sort of the political process, which really comes down to citizen engagement from start to finish.
Eve, are you going to? I know you are, but okay. So there are 2 more people standing to ask questions. I'm going to call that a night when those 2 are done. You are up first, Joel.
I was just wondering, I appreciate very much the complexity of your expertise, everybody. But I'm just wondering if there isn't still a way of cutting through the complexity that we all know, and that is that medical care is a right, period. Absolutely a moral right. End of discussion. It is not complicated. That what's complicated is the pernicious profit-making healthcare insurance program, and that the only way to address this finally is to step back from the infinite complexity that the healthcare insurance profit-making industry places before us and confront the moral right that everybody, period, has a right to medical care, and that the only rational solution to that is the universal health care. The rest is a fraud.
Thank you.
Eve, you have our last word.
Okay. This is a question for the navigator. I have been, yay, insured by Mass Health, Connecticut. I've been insured by it all. My partner is insured by GHI, or GIC, sorry. Too many insurance numbers. Cat's out of the bag that we're going to get married. And do I have to go on his insurance, or can I keep my Mass Health?
Stand up for the mic there, John, if you would.
I've heard it both ways.
Technically, you'd have to go on his insurance.
Okay.
Okay, but some of that also depends on income. There's a lot to look at there. You should probably call.
That's where we brought him. All righty then. We'll wrap that.
We have cards up here.
Yeah. Okay. No, I think I know your number, John.
Okay.
I'll call you. Thanks.
Well, I just want to thank every one of you in the audience for the wonderful questions tonight. I want to thank the Citizens for Healthcare Action for making this thing work. And as I said at the outset, the people to my right were way smarter than I was. Mike Knapik, Jackie Wolf, Eliza Lake, thank you all. Make sure to take handouts, talk to your navigator. Good evening.
I have copies of my slides if anybody wants. I have a few.